Now turn it over to Dr. White to argue against.
First of all, I'd like to thank the organizers for allowing me to participate in this discussion today. And as we heard, what we're talking about now is that should 5-fraction whole breast irradiation be the standard of care? And the themes that I'm going to speak to today are listed here, talking about the evolution of whole breast irradiation fractionation, the fast and forward clinical trials as I see them, and really I would like to focus on breast radiation treatment planning in large fraction size and radiation delivery, and then touch on the idea of standardization versus individualization. So I've listed here, before I go forward much further, some common terms and abbreviations that I will have throughout my slides that I think that might be of use if you're a non-radiation oncologist listening today to us speak. So I always find that it's very helpful for me, whether I am seeing patients in clinic or whether I'm participating in a discussion like this, to always go back to my goals for radiation following lumpectomy for breast-conserving therapy. And I want to make sure that I secure in breast cancer control post-lumpectomy for that patient on par to what she expected with mastectomy. And secondly, and as importantly, to preserve the breast aesthetic appearance and sensation, meaning how does the breast look and feel? And I think mathematical modeling has played an important role in how we understand and optimize radiation delivery for the treatment of cancer. And here in its simplest form, you can see the linear quadratic equation estimates the radiation total dose and dose per fraction for the same biologic effect. The UK fractionation trialists, led by Dr. Cole, have been trailblazers for evaluating the clinical application of this to reduce the number of radiation treatments or fractions for breast cancer, and deserves incredible recognition for this body of work. I have outlined here this whole breast radiation fraction evolution over time, going back nearly over 40 years now, and the number of clinical trials that have supported the practice. And you can see in the conventional fraction era of 1.8 to 2 gray, there's innumerable trials that supported radiation delivery like this. Moving on to the moderate hypofractionation trial era, which I believe is where we still are, of 15 to 16 fractions of 2.6 to 2.7 gray, about 30% higher in dose. We now have several clinical trials that help us understand how to do this. And now today we are focusing on fast hypofractionation of 5 treatments with over 5 gray per fraction, for which we have 2 good studies from one set of investigators in one clinical practice setting across the UK. So looking further at these very successful trials, this is the first trial, the fast fraction trial, looking at using 5 fractions of whole breast irradiation over 5 weeks. And they examined as their standard arm actually 50 gray and 25 fractions, and looked at 2 test fractionations or 2 experimental arms of either 6 gray per fraction to 5 weeks, or a total of 28.5 gray. And you can see the primary endpoint on this study was change in photographic breast appearance, as we heard. With 915 patients randomized, you can see they're a fairly low-risk population of an average age of 62 years old, and nearly 90% of them were grade 1-2, average small tumor size, and nearly 90% tamoxifen or AI treated. And as we heard, there was no statistical difference between 5-week breast radiation of 5 fractions to 28.5 gray compared to 25 fractions and 50 gray. And I totally endorse that. What I would like to focus on is that the 5 fractions of 30 gray total had significantly more breast appearance changes, as seen here in this table, and as we look at the risk ratios for marked change in the breast appearance. At 10 years of data, this showed, with nearly 10 years of follow-up, very low in-breast recurrence rates were seen on this trial, which you would expect with the very low-risk population. Again, the breast appearance findings persisted with no difference between the 25 fractions to 50 gray and the 5 fractions to 28.5 gray. But there was moderate to marked adverse breast effects at 5 years again, when you look at the 30 gray fractionation, 30 gray total dose in 5 fractionations, and the 28.5 gray in 5 fractionations. And as we heard before, this continued at time with a more downhill slope seen, a quicker downhill slope seen, for at least breast shrinkage with the, that should say 30 gray, excuse me. For the 5-fraction whole breast irradiation groups, what was remarkable to me about this data, and still is, that small difference in total dose from 28.5 gray to 30 gray, a 1.5 gray difference, leads to a significant impact on breast appearance. So now the UK fast-forward trial, as we just heard again, looked at 5-fraction whole breast irradiation in 1 week, undeniably a great convenience for patients and will promote improved access in some practice settings. They this time had a broader eligibility criteria and randomized over 4,000 patients to the primary endpoint of ipsilateral breast recurrence. And the control arm this time was the 40 gray and 15 fractions. And again, 2 test doses, experimental doses. This time, 5 fractions up to 27 gray and 5 fractions up to 26 gray. The broader eligibility criteria led to a more modestly high-risk population, but still, nevertheless, the mean age was 60 years. Nearly 90% of the patients were hormone sensitive. The tumor size on average was 1.6, and most were grade 1, 2, or T1 tumors. At a median follow-up, though, of approximately 6 years, there is the ipsilateral and breast recurrence is non-inferior, as we see across all three arms. And this is really important validation of the application of the linear quadratic equation, saying that you can model out that fraction dose and that total dose to know the same effect on cancer control. However, again, what I'd like to call your attention to is on the fast-forward 5-fraction arms, there's a small difference in total dose from the 26 gray to the 27 gray. 1 gray difference had significant impact on breast appearance and at adverse events, demonstrating a very narrow toxicity threshold. So let's see, how does this serve? How do these data serve my goals or our goals for what we want from breast radiation? Well, I think undeniably, and there's a lot of credit, it demonstrates that you can use that linear quadratic equation to model isoeffective outcomes from different fractionations and dose schedules. We can secure in breast cancer control post-lumpectomy on part of that expected with mastectomy in this predominantly hormone-sensitive early-stage population by using that linear quadratic equation. The place where I have some difficulty and some concerns is with the narrow toxicity threshold. And my concern is this threatens that preservation of the breast aesthetic appearance and sensation, or meaning how the breast will look and feel. So as we heard before in the prior presentation, and I present here today, this is the subgroup analysis presented by Dr. Brunt for the study team looking at the marked moderate clinician-assessed adverse effects. And without a doubt, as we heard, clinician-assessed moderate or marked adverse effects for the 26 gray and 5 fractions versus the 40 gray and 15 fractions showed no evidence of a differential effect on their statistical analysis. However, I think others also look at this one trial study and say, and this is from Dr. Krug from the breast cancer expert panel of the German Society of Radiation Oncology, looks at this and said, well, if you look at this, the hazard ratios and odd ratios indicated a trend in favor of the standard arm of 40 gray and 15 fractions for most of the analyzed items. So again, there is some doubt that all that we need to understand about this can come from this one trial based in the UK practice setting. I think it's important to go back and examine radiation treatment planning to understand where the opportunity might be to improve the outcomes and reduce that narrow threshold toxicity. So conventionally, when we plan radiation for breast cancer, and this is globally, the focus is on minimizing the maximum dose, meaning making sure the dose is as homogeneous as possible. And this is illustrated here on the fast-forward trial treatment planning guidelines, where they specify the upper dose limits of less than 5% of the breast volume should receive greater than 105% of the dose, less than 2% shouldn't receive any more than greater than 100%, 7%, and a global max of 110%. And this is really, these are actually tighter constraints you'll see others use, and this is very common in breast cancer treatment planning. However, the difference between 5 fractions to 26 gray versus 27 gray to total dose is 4%. So that narrow toxicity threshold is well below what we would consider the upper limits of acceptable dose maximum. So let me illustrate it on these two cases. These are both cases that would have met the upper dose limits for the fast forward trial if they had been enrolled. All patients were treated supine on their backs, and this is showing the guideline of less than 5% of the breast volume should receive greater than 105% of the dose. And as you can see on the left side, a very large breast, the volume of greater than 105% is 140 cc's, much larger, nearly 10 times than the volume receiving greater than 105% in the smaller breasts on the right. So the volume of 13 cc's. We know in the practice of radiation oncology, when other disease sites have moved to large fractions per treatment of greater than 5 gray, they have found that it's important to be careful about the absolute volume of tissue receiving the highest dose, and also to very much focus on how the dose conforms or surrounds the target we're treating. And this might be an opportunity for us to learn that what got us here with standard conventional fractionation and moderate hypofractionation will not take us forward with very large fractions of greater 5 gray per day. So perhaps the area to look at is within the thorax anatomically as well as breast, and that's in medically inoperable lung cancer. And this is a very notable and dramatic example where the delivery of radiation with very large fractions of 20 gray had significant associated toxicity. In fact, and Bob Timmerman reported this phase 3 trial out in 2006, phase 2 trial, there are 3 fractions of 20 gray to 22 gray. Patients who had medically inoperable lung cancer in the central or perihilar region had a 45% risk of grade 3/5 toxicity. However, more recently in 2019, Energy RTOG 0813 phase 2 trial focused just on centrally located medically inoperable lung cancers, was able to show a reduction in that risk of grade 3, grade 5 toxicity down to 7%, and other studies have now shown no grade 5 toxicity. And they did that by reducing fraction size, increasing time interval, and then most importantly, defining very strict dose, target, and absolute volume parameters for how to do this safely. So this is probably an example more relatable to what we're talking about in breast cancer. And this is addressing chest wall toxicity from lung SBRT, where 25 to 25% of patients who medically inoperable who undergo SBRT for non-small cell lung cancer will suffer from chest wall toxicity. Well, the Cleveland Clinic looked at their experience with that, and they really focused this on 3 symptoms: neuropathic pain, rib fracture, soft tissue induration, and studied patient and treatment variables that could help identify patients at risk. And what they found was that there was no patient's variable identified, and but if they reduced the fraction size, it reduced. But importantly, if they looked at very specific volumes, absolute volumes of high doses, they could even reduce this risk further. So putting this all together in terms of breast planning radiation considerations, first of all, I want to again emphasize that this is a success in showing that the linear quadratic equation models have been successful in predicting cancer outcomes and give us a lot of freedom in how to customize the delivery of total dose and dose per fraction to suit patients' needs. The experience with breast cancer radiation treatment planning, based on decades of 1.8 to 2 gray and moderate hypofraction 2.6 to 2.7 gray, which is a 30% increase, has gotten us to the point where we think in treatment planning it's just dose homogeneity. We have very limited experience, very successful limited experience. This trial is a success, let me make that clear again, but it's over 200% increase in dose per fraction in breast cancer treatment compared to other disease sites. Dose volume restriction and conformity of dose to a breast target may now be important and are likely going to be important with large fraction breast irradiation. Furthermore, I'm shown on this figure here, this transaxial slice of one of my patients. This is how I treat here in the United States. I can't relate to what I see in terms of how things were delivered on this trial for how it was done in the UK. My patients are, for the most part, and not just me, many centers, treat prone. And in a young woman like this, I use a boost. There are randomized data showing that when you give higher dose to the area around the lumpectomy cavity site, where there's the highest risk of recurrence, you can reduce the in-breast recurrence by about a relative 20% or so. So I don't know from the data so far from this one trial how I can do this safely and preserve this young woman's long-term look and feel of her breasts going forward. And I think that this becomes quite important in the United States with a broad implementation at this point, because quite frankly, breast cancer patients do not follow up with their radiation oncologist after they complete treatment. This is a SEER Medicare-linked data set showing that follow-up visits with radiation oncologists after lumpectomy and radiation is pretty good in year one, whether there are 2 doctors following them, just one doctor following them of one specialty, or more than 2 doctors. But it falls off to less than 25% by year 2 and is less than 5% by year 5. So quite honestly, if we implement without further understanding, will radiation oncologists be aware of poor outcomes from implementation of 5 fractions over 5 days? Now, having said all that, let me tell you that I think that the 5-fraction whole breast irradiation is an important addition to the breast radiation armamentarium. This is a case that I use this fractionation in select scenarios. This is, for example, is a 74-year-old woman in otherwise good health, excellent performance status with Schomburg index of 4 to 5. She had a lumpectomy and sentinel node biopsy for a triple negative breast cancer that was 2.3 centimeters in grade 3. She underwent her chemotherapy well, and she lives an hour away from our center, and we talked about the data from the fast forward trial and the potential for toxicity being fairly low and what this meant to her. And she and I came up with this decision. So at my institution, she didn't want to come every day. She doesn't want to come Monday through Friday. She doesn't want it to go 5 weeks either. So I'm lucky that I work with a physicist who has radiobiologist training, and he actually figured out this fractionation for us using the linear quadratic equation, 28 gray, 5 fractions every other day for 2 weeks. And she was happy with this and treated successfully. So in summary, I think this case illustrates that nearly all treatment decisions involve some trade-off between therapeutic benefits and risks. And some patients are willing to accept potential late risk with large fractions and others will not. And that the patient voice is necessary to add individual values such as trade-offs between potential risk versus brevity of treatment. But because a patient might be willing to accept this, and because there's need across the globe, does not mean that this should replace additional efforts to mitigate toxicity with additional data. There needs to be additional prospective data to inform best practices for radiation delivery with large fractions outside a solitary clinical trial, no matter how successful that trial is, and it's still needed. And I think I've shown the picture of Lady Justice here because I think this demonstrates the need for equipoise to be able to move forward with us without saying that the sum total goal of our radiation should be that it's 5 fractions. So finally, I just want to discuss further about breast irradiation after lumpectomy, because we're talking today a lot about standardization. And I think that in this era of precision oncology, I think the emphasis we always want to remind everyone of is that the goal should probably be individualization more than standardization. And that one size does not fit all in this scenario. There's been a lot of work, particularly done by the UK group and many other clinical trial groups, looking at many different ways for us to meet the needs in the cancer control for women post-lumpectomy that fit both of those needs of maintaining cancer control and preserving the look and feel of the breast. In low-risk luminal cancers, stage 1 hormone sensitive, HER2 negative, in combination with endocrine therapy, there's accelerated partial breast irradiation that has 5-day radiation delivery and has multiple randomized trials with 5 to 10 years follow-up. We now have multiple ongoing phase 3 trials looking at observations. Maybe we don't need the radiation. We have higher risk breast conservation with boost in triple negative and HER2 and higher risk luminal. There's concomitant boost with 15 fractions over 3 weeks that we saw the UK Import High report on, and there's numerous other trials behind that pending. So looking at just a 5-day fractionation difference between 5 gray with a boost, 5 gray fractionation whole breast irradiation with a boost. So there's many ways that we can customize this to meet patients' needs. In particular, for some reason, there's been very little uptake of the 5 treatment delivery days of accelerated partial breast irradiation. It's all with hypofractionation, and there's 4 trials showing that it's non-inferior to whole breast irradiation with very long follow-up of over 10 years in some instances. Furthermore, there's comparable cosmetic outcome from accelerated partial breast irradiation when compared to whole breast irradiation in 4 out of the 5 trials that have been conducted in this space. And take this into consideration when you're looking for a good 5 treatment day option for your patient. So my closing thoughts are this. First, kudos and hats off to the UK fractionation clinical trialist team for the success of the UK FAST and FAST Forward clinical trials. They totally continue to help move us forward and demonstrate that the clinical application of the linear quadratic equation with a breast cancer alpha beta between 3 and 4 can predict ISO effects of cancer control in this predominantly hormone sensitive and early stage breast cancer population. I think and I hope I've shown you that large fraction size has a narrow window for higher risk of toxicity. This is not unique in breast cancer. This is unique across the practice of radiation therapy. And then what got us here in terms of treatment planning, focusing on homogeneity, primary dose homogeneity, will not get us where we need to go when we start using large fractions and need to focus on absolute doses and conformity of the dose around targets. We need additional prospective outcome and treatment planning data to facilitate implementation optimally to minimize harms. Breast radiation should be individualized to the disease risk, to maintain breast appearance, and to meet each patient's values and needs. And I want to thank you so much for your attention today, and thank the many people at my institution across the globe who have given me feedback on this. Thank you again.
Thank you so much to both of our speakers for these outstanding talks. I hope that shortly we'll see Charlotte's face show up. Fabulous, and there she is live. Wonderful, wonderful. So I'm going to give you each a minute to offer any sort of closing or rebutting comments, and then we'll turn to the questions from the audience. So we'll start with you, Professor Coles.
Well, I just want to say thank you to Julia for a really great talk. Just to clear up a slight discrepancy, completely agree about risk-adapted radiotherapy. In the UK and elsewhere, of course, there are patients who have no radiotherapy. We give 5-fractioned 26 gray and 5 fractions for partial breast radiotherapy because the import load trial was designed in parallel with Fast Forward, so that's been adopted. And we also give simultaneous integrated boost, and that is also allowed as part of our UK consensus, and that was presented at ESTRO. And we're moving towards proton beam therapy as well in terms of trials. So completely agree with that. In terms of the normal tissue toxicity, I think I would just draw your attention to the clinical trial results that we had, and these were very, very low. What we also know is that it's important to reduce the total dose. So with 26 gray and 5 fractions, it is still gentler on the normal tissues than 50 and 25. And with a very stringent quality assurance, and we showed that there was no difference between the 2 arms in terms of patients with larger breasts. And I've also shown you the data about double trouble. There was no issue there. It's important that we give good radiotherapy. So I also want to raise the question that the actual, in terms of the side effects, they were so very, very low. So that's important. In terms of subtypes, well, over a third of the patients were high risk. So that's over 1,000 patients. And over 400 patients were under 50. And in terms of the data that I showed you, in terms of the subgroup, yes, the event rates are fortunately very, very low, but there is actually no evidence or no scientific rationale against any subgroup. And if we turn the clock back 15 years, we were here with 15 fractions. And we now know that with the meta-analyses that there's no difference in terms of hyperfractionation with any different breast subtype. and there's no reason to suspect that that will be different with 5 fractions. There are other things that I can address, including the paper by Dr. Krug, but that would take a little bit longer, but I'm more than happy to talk about that methodology. So I guess my bottom line is that it's important that 26 gray and 5 fractions is an effective regimen for tumor control, and it's very well tolerated as moderate hyperfractionation, very similar to 40 gray and 15 fractions. And we add boost as needed, but boost volumes are kept small.
Thank you, Dr. Coles, Professor Coles, and we'll turn it over to Dr. White.
So I don't want to take up too much time, because I think we want to get to the questions, but let me just respond in a couple of ways. And I respect how great that trial was and how much work that is. I think we know that quite a bit. So, I think I first want to talk about the populations. So we have a habit in clinical trials, and particularly when we run local regional trials in low-risk populations, that we add a small percentage of population that has a higher event rate because it helps our statistics. And we're guilty of it, other trials are guilty of it. But then when you have the trial end, it makes it very hard how you interpret the statistics, the overall statistics, that may be driven by small populations. So I don't disagree with any statement, but I do think we have to just say that both populations, it looked like almost 90% were given endocrine therapy in both trials, and I assume that's only being done for hormone-sensitive patients, that the populations and the data, not for toxicity, but for cancer control, speaks to that. I'm not saying it doesn't work in the other ones, but that's where the data is right now. So I think the other thing I want to talk about is that I am not discrediting or diminishing the accomplishments of the quality assurance and everything done on this trial. When I look at it, however, though, and I think it's shown across radiation oncology, when you get to larger fractions, greater than 5 gray, there's a narrow toxicity threshold. It is there. So the issue is, how do we move forward to implement this, and at the same time continue to advance our science and advance our knowledge base? I think to say, well, it's only a small percentage of women who will get this. Let's say it's 3%. Well, in the United States alone, 200,000, let's do the numbers, 200,000 new breast cancer patients per year. More than 50% of those are receive breast conservation. That might be, so over 50% are stage 1, 70% receive breast conservation. So now we're up to about 70,000. My math, I have a colleague here who does math all the time in his head. I can't do it. 70,000. So then we're going to say, of those 70,000 women getting radiation, that 3% or so does that mean 2,000 women per year, it's okay for them to have that? So I'm just saying we just have an opportunity here in breast cancer radiation to really go back and reevaluate how we deliver radiation and to learn how that may change using fractions greater than 5 gray. I don't think we really get those answers when we go back and look retrospectively and try to model it out on patients who've already been treated with moderate hypofractionation or the 1.8 to 2 gray per fraction. So I just think there's still opportunity here, and I'm just going to leave it at that.
Perfect. And thank you to both of our debaters for outstanding points. I'm going to turn it over to the questions in live audience. The first one from the virtual that I'm going to ask to Professor Coles is just to highlight what boost dose do you give? What are the details of the boost when you do give it?
Okay, so we discussed this at our UK consensus, and we give a hyperfractionated boost dose, so which is either 2.67 gray times 5, but we also allow the 48 gray in 15 fractions SIB as part of the import high trial as well, so that there's choice here for patients. So it's either a 2-week or 3-week treatment. In terms of simultaneous integrated boosts, that has advantages as well. It's beyond the remit of this debate, though, to go into that boost side of things.
Thank you so much. And we'll take a question from the audience.
Yes, thank you very much for the debate. My name is Philip Portmans from Belgium. So there are a number of points, I think, but we have other questions. First of all, a statement. we treated the first patient in Antwerp with the 26 in 5, the 24th of March 2020. It became the standard after 2 months getting the experience for all breast only and chest wall only. If the patients have an indication of a boost, we give in times of COVID 1x6 gray. But then we come back to the volumes, because there, Julia, is a very important point. The volumes have to be small. A boost volume should be a couple of tenths of cubic centimeters, not like the example that we have seen. It should be much smaller than that. Also, the breast example, the right one from Kuhn, the volume of the breast is too large. It goes beyond the margins of the breast glandular tissue. And then a thought, Charlotte, you're a clinical oncologist, so you treat with radiation and with systemic therapy. So you know both worlds. It took us 10 years to get moderate hypofractionation implemented in, let's say, 1/3 of the world, because still the majority gives 50 and 25 fractions. Now, are we going to take again 10 years to implement ultra hypofractionation? Imagine your medical oncology counterpart. Wouldn't we still be giving CMF nowadays if we would do the same towards medical oncology approaches?
So can I just comment a little bit? So I don't think that in the setting, CMF was replaced by a superior regimen. We are talking about regimens that have, again, fairly equivalent outcome. And we are not saying, and this is not about whether it's right or, I don't think that we can legislate within this conversation things about healthcare policy and what people should be doing regarding number of fractions. This is whether it should be standard, and because there's nothing more need to be done from this one trial. So I do think, I want to talk particularly about boost. Where I practice, it would be considered unsafe if I were to start my radiation plan without a composite plan demonstrating the influence of boost on the overall distribution of radiation. So I think this is a very key, important point to understand, that when we're going to take, particularly after 5 fractions, and take something to an even higher dose, you have to be very mindful of the absolute volumes going to those doses and the conformality, as was pointed out. The question is, I don't think we know what those are right now. We'll get there. I just don't think we know them right now.
I'd like to come in too, as well, if I may, about boost. So what we do in the UK is test one parameter in one trial. So fast forward was 5 fractions, import high was looking at SIB. What we're working towards, and it will be Anna Kirby who leads this, is to be looking at a 5 fraction SIB. And I completely agree with you that we need to be looking at the whole, the boost, how the boost relates to the whole dose when we plan up front. Now, the boost volume for import low for the median was only, CTV was only 13 cc's, and we had fantastic local control in a high-risk population. So the plan will be eventually to move towards a 5 fraction SIB, but we need to do that slowly, but that's the line of sight.
Another question from the audience.
Thank you for that wonderful, spirited debate. My question is financial. Are there large savings giving 5 fractions versus 15, 16, or 25? And secondly, if that would cause a saving to the community and the payers, would you aspire to that money being reinvested in parts of the world that do not have adequate facilities?
So if I could just say that I think, of course, I think I'm an optimist, and I think that everybody in their heart wants that. I mean, that's what we all go for. But I think that there actually was a very nice poster at the poster session yesterday using healthcare claims costs, showing that when you went from 25 fractions down to 16 fractions across the United States, the actual difference in claims is about $5,000. And that's important when you add it all up. But I don't think that argument means that we should ignore the potential toxicity to individual women and say it's okay. And I think that's the point that I'm pointing out on this. I 100% agree, but I think legislating the costs of breast cancer treatment, and to be honest with you, we have to be very fair about that. So let's say, Alistair, that we do this and that 1,000 to 2,000 women have horrible cosmetic outcomes, and now they go on for their plastic surgery repair. Well, there's hundreds of thousands of dollars per case. So I think we have to be careful, and in this conversation, I think that's outside the scope of are we ready to go based on one trial, excellent trial, done in the UK.
Last comment to Professor
So if I could come back on that as well, I completely agree with Alistair. It's a happy consequence of the trial that it saves money. It's not why we did it. We did it for really good, high quality radiotherapy, for good local control, and very, very low toxicity. I'm a little bit bemused at the toxicity argument because the only statistically significant difference in toxicity was in duration outside the tumour bed, and that was just over 1% in 26 Gray. And this is tiny. So I don't think that argument holds. What I do think is important is that we're able to actually treat people in countries that currently have no radiotherapy. So I think this will be really important, but it's not going, I hope it will be introduced because of very good evidence and high quality radiotherapy.
With that, we are going to let you have the last word, and we will turn to our re-poll. The question is live, if you are willing to log on and answer it, and we'll see if we have changed hearts and minds.
Did you want me to say last word?
Oh, I was calling that the last word.
Yeah.
Sorry.
Okay.
I think
We've turned to the poll, and I will tell you that for the premenopausal ER negative patient in the initial poll, the majority said that they would choose the 15 fraction. And we are seeing some transition now where we have 45% who are saying they would take 5 fractions without reservations, 14 with some reservations, and still a quarter who would lean towards the 15 fractions for the ER negative patient. I will go ahead. We have about 50 or 60 people who voted at this point. We had 160 in the first poll. Still continuing. It's like watching popcorn pop.
I know.
As it begins to slow down, we'll
And no ding.
hit the ding, yes. I'll close it out at 100 if we get there. We'll call it at 92. So here we have, for the premenopausal patient, a third would give whole breast without the 5 fraction without reservation. Another 20%, so a total of 50%, half would go for 5 fractions. And then you have 30% for 15 fractions and 10% who need more information. And we will go to the second one. This is probably the softball. This is the postmenopausal patient with an ER positive breast cancer. I'm not sure where there we go. And here we started with a very favorable 5 fraction uptake. And as the numbers continue to roll, we see that that has increased slightly with a little more confidence in this patient population represented by the trial. Here we are still heading towards 100. We'll close it up about there. So here, as we approach 100, approximately 85% of respondents would choose 5 fractions for this patient, with or without reservations. 10% would stick with 15 fractions here, and 5% would like more information. I'd like to thank both of our presenters who have done an outstanding job, all of our audience members for participating here and virtually, and of course all of the patients who are involved in these decisions and are of course front and center in trying to find the right personal decision. Thank you so much, everyone.